So the theme of this Seeing is Believing webinar today is on gender. So the presentations today will explain some of the barriers women face as well as the strategies SiB projects implement to ensure women and girls access quality eye health services. So firstly, I'm pleased to introduce Samrana Yasmin, the Regional Director from Southeast Asia, Eastern Mediterranean, Brian Holden Vision Institute, to give an introduction to some of the barriers women face accessing eye health services in the Southeast Asia region. So I'm just going to unmute Samrana. So Samrana, over to you.
Thanks so much, Susan. Hello, everyone. Greetings from Islamabad, Pakistan. I'm very excited to be part of this webinar, which is highlighting the issue which is very close to my heart. Gender inequity is a pressing global issue with huge implications in all aspects of life. It's not about women and girls only, but actually it refers to the social attributes and opportunities associated with being male and female, and in their specific role in their specific context and localities. We know that no society can develop successfully without providing equitable opportunities, resources, and life prospect for women, men, girls, and boys in all their diversity. When everyone have relative equality, economies grow faster, children's health improve, and we collectively move towards sustainable development. In eye health sector, we are faced and we continue to face many barriers when it comes to delivering more gender-responsive program in various settings. The first one which we encounter in our region are barriers to access for females and young girls. It's more difficult for them to reach and utilize eye health services. Most of the population in this part of the world is based in rural communities, and good quality eye health services are less available in those areas. Eye care professionals hesitate to go and work in remote settings. Cost and affordability is one of the major costs which comes across a lot whenever we talk about these issues. Poor infrastructure and poor transportation facilities further contribute to these barriers. And we know the impact of reduced access for women, especially young girls. That means that they miss to achieve their full potential in life. We also see lots of barrier at policy level. Our policy and development forums in general have less or no representation of women, including the one which are specific to eye health. And this automatically results in less gender-sensitive eye health services and program development. And most of all, we face cultural barriers. In our societies, women have limited or no decision-making power. They have to get permission from family head to get eye care. We see women leaving eye care facilities, optical stores without spectacles because they can't decide to buy something without a yes from somebody responsible from their family. And something as simple as a pair of spectacles, which cost as less as $1 or $2 in our part of the world. And then there are myths and taboos associated to the use of spectacles, especially for young women and unmarried women, which has direct implications towards their education, employment, and economic independence. The situation can be as worse as that in some communities in Papua New Guinea, women can get killed if they wear spectacles because they are assumed to be witches. Horrifying, but this is the reality we are living in. The list of these barriers can go on, but the heartening aspect for all of us is that there is this growing conversation about gender equity in eye health. We know from experience and evidence that by engaging both women and men as gender champions at all levels, and most importantly at community level, we can bring a significant change. Our learning from SiB Phase 4 in Sri Lanka reinforces these facts, that by bringing services closer to communities, by making sure that we respect and embed local gender-specific context and local voices in program design, budgets, and implementation, and by leveraging and diversifying our partnerships and including more women group into these discussions and debates, we can deliver more gender responsive intervention and we can generate evidence for advocacy. At a personal level, I also strongly believe that all of us in our individual capacity have to be the change to bring a positive change in our programs and for our communities where we work. Thank you very much.
Thank you, Samrana, for that insightful overview. Thank you. Thanks so much, Samrana, for that. Thanks for that overview of just to give us sort of the background of the context of what we're going to be talking about today. So I've seen a few people who've introduced themselves. So I'm just going to read out a couple of names. We've got about 30 people on the line now. So we've got Teresa Bird from CBM UK. We've got Ramesh Puri from the Regional Director for Southeast Asia and Middle East. So good morning to you. We've got Manfred Morkan from CBM Asia Southeast Philippines. So we've got a few people, and we've got Dr. Situ Wai from Fred Hollows Foundation in Myanmar. So welcome to all of you. Very happy to have you all here today. So now we'll move on to doing our presentations. So I'm now going to introduce Erica Katran, the Country Director from Hellinkella, Myanmar. So Erica, I'm going to unmute your microphone and then, do you want to unmute your microphone and then over to you?
Great, thank you, Susan. Good morning or afternoon, everyone, depending on where you're calling from. I'm speaking from Yangon, Myanmar, and talking about gender issues we've encountered in our cataract and primary eye care program here in Myanmar. So you can go ahead to the next slide, please. Susan, oh, thank you.
Yeah, so there's going to be a little bit of a time delay between me clicking for the slide and the slide going. So just carry on with the presentation, and then yeah, I'll keep doing the slides.
Okay, great, thank you.
Sure.
So the project I will be talking about is called CAREX, and this project aims to reduce the prevalence of visual impairment and avoidable blindness in the dry zone of Myanmar. And we do this by working at multiple levels of the government healthcare systems. So we work with secondary eye care centers and rural health centers to improve the quality of cataract surgery and other eye health services. And then at the community level, we work with basic health staff, who are mostly midwives, to train and support them to conduct primary eye care visits and identify and refer cataract cases. So these basic health staff are really the backbone of the rural health system, covering 70% of the country's population. And in most cases, they've had very limited exposure to primary eye care and very limited linkages with the secondary services. So in most cases, not really taking any role in terms of identifying and referring eye health problems at the village level. So in Myanmar, there certainly are some specific challenges which women face. Domestic violence and women's higher workload in the household are the two biggest issues. But overall, in terms of how decisions are made around, oh, you can go back, please. Decisions around accessing health services and spending income really is quite equal within Myanmar. Both men and women are quite free and able to participate in income earning activities, and there's gender parity in education right through the secondary level. So what I will actually be talking about is more in terms of barriers for men. As Samrana mentioned, gender is not only about women and girls, and in our project, we've had actually the biggest challenges in terms of reaching men. So in terms of CARET's targets around gender, we hoped that men and women would benefit equally from access to cataract surgery. However, throughout the project, we have found that many more women than men are accessing cataract surgery. So we aim to achieve 14,400 surgeries overall, but as of the end of June, we had reached 17,000 surgeries, but most of that overachievement was among female patients. So we aim to reach 7,200 men and the same number of women. We've achieved about that many men, but almost 10,000 women, so quite a bit more. Men's levels of surgery also tend to drop during busy agricultural seasons. And although it was not really part of our initial targeting, we have been monitoring the differences between surgery outcomes and have found that it's quite similar for men and for women. So why are we seeing so much more progress in terms of access to cataract surgery for women versus men? So as you can see in our Inception survey, we did find that women tended to be much more aware of eye health problems. So about twice as many women as men reported having had an eye health problem. And per the earlier slide, women do have slightly more eye health problems, but not enough to explain this difference. And there's also quite an interesting difference in terms of how men and women sort of quantify and understand their eye health issues. So for both men and women, fear and lack of awareness are the main barriers to seeking surgery. However, these factors were much higher for men versus women. And as mentioned, most of the rural health services are provided by basic health staff, who are primarily midwives. These midwives tend to visit rural communities in the late morning or middle of the day, and as a result, men often miss these visits when they're out working in the fields. So men might also feel that midwives are really there for women and children, so they don't seek out their care. Also, what we often see in Myanmar is that after a midwife makes a village visit to do primary eye care, people who have cataract or other eye health problems will plan to travel to secondary eye care centers together and will often work together to seek support from a local donor. So we think that women's stronger social ties may encourage stronger care seeking. So to be frank, at the outset of the project, we didn't really anticipate that men's access was going to be such a challenge. So this wasn't built into the initial project design, but we have taken some steps to address it. So one of the biggest things we've done is develop a package of behavior or IEC materials that can be displayed in rural communities and provide another avenue of communication for those who are not able to frequently access the health staff. So we did quite a bit of field testing to develop a story that would really resonate with how care seeking is the pioneer, and if they have good results, others are encouraged to seek care as well. Probably the biggest change that we have made is really increasing our engagement with volunteers. So I talked about the basic health staff, or the midwives. They are also supported by village health volunteers who are registered and trained by the government to do vaccination, antenatal visits, and other kinds of basic health services. So they are trained, and then they do health education and the other activities in the villages where they live. They're there all the time, and men and women are able to access them at any time, not only during specified visits. So we initially had planned to train about 1,300 volunteers, but ended up increasing that number by about 1,000 as a way to increase really contact and education for both women and men, but saw it was especially important for men. So it's one pretty basic training followed by township meetings, which are refresher trainings. We also tried to work within our approach of integrating eye care into the formal health system of the secondary eye care centers, the health staff or midwives. One of the things that we did is in the refresher training for basic health staff, we really encouraged them to find ways to reach men, including when they meet with women, to encourage those women to share information with their husbands or other men, and to encourage those men to seek out the support of the basic health staff if they had a potential eye health problem. We also worked with the secondary eye care center staff to really encourage them to support patients in sharing their experience with other community members and really using them as a conduit to spread information about the services available and the really positive outcome that the patient found from cataract surgery. So in conclusion, while we have achieved our targets for both men and women, engagement of women has been much higher, and we feel that more could be done so that men are as engaged as women. For men, the village health volunteers were really the most effective avenue for engagement, while basic health staff really did work well in terms of reaching women. So the CARE project was really designed around integration of primary eye care into the existing health system that covers Myanmar's rural areas. However, it does seem that this system might not be effective at engaging men, and other avenues could be explored in future projects. So, for example, monks and religious leaders that tend to be very well respected and have quite a bit of influence over both men and women. So thank you.
Thank you so much, Erica. Thank you for that presentation and for highlighting some of the challenges the project has seen in encouraging men to access services, as well as some of the strategies you're implementing to increase their access. And it's really interesting that whole, by looking at the data and by looking at which groups aren't accessing, then you can think about which strategy is relevant for them. And it might not be the same strategy you would use for a different group that was struggling to access. So thank you so much for that. Just as a quick reminder, if you have any questions for any of your presenters, if you can please now start typing them in your chat box, and then after all of our presentations, I will ask our presenters your questions. So it will be interesting to compare our first presentation with that of our second from Roshan Bista, which will also discuss some of the challenges and strategies, but in their context developed for women accessing services at the secondary level. So it's my pleasure to introduce Roshan Bista, the Programme Coordinator from SiB Cambodia. So Roshan, I'm just going to unmute your microphone, and Eric, I'm going to mute you.
Yes,
So
yes.
Roshan, just 1 second so I can bring your slide up,
yes.
and then it's over to you.
Yes, thank you.
Please go ahead.
Yes, thank you. So, my name is Roshan Bista, Program Coordinator of SiB Cambodia. So, I would like to present the gender. The SiB is Believing initiative support in 5 provinces in Cambodia. And our main goal is to prevent and treat unnecessary blindness in 5 underserved provinces in Cambodia, and increase cataract surgical rate from 1,747 to 2,500. And our main objective is to increase community eye health, outreach and awareness in 5 provinces, and also increase eye care service provided by partner eye clinics, and conduct 9 outreach eye camp, and increase local capacity to screen and provide eye care, and also reduce gender inequities and accessing care in all partner eye units over the 3 years, beginning from July 2016 until June 2019. So the slide, blindness and eye care in Cambodia. The population in Cambodia, around 14.7 million, and in SEA catchment area, in 5 provinces, over 3.6 million, and the blindness over 53,000. And currently, the National Program for Eye Health mentioned that the target to reach the cataract surgical rate by 2020 is 3,000, and in 2016 in Cambodia, this cataract surgical rate achieved 2,180. Next slide, please. Yes, in Cambodia, of 14.7 million population, over 51.5% female and 48.5% male. So the rapid assessment of avoidable blindness also mentioned that the prevalence of blindness among the female is over the 50 years is 4.4% compared to 2.7% for males in same age. So we identify some barriers working with the community, and especially barriers for women for eye care service is the man cannot afford for the services. In government eye unit, they have the cost recovery system, and they have the fee schedule. but the majority of people in rural area, they could not afford, especially around 41% of the people living in Cambodia living less than $2 a day. So majority of them cannot afford for service, eye care service and surgery. So that is also one of the barrier. And second, lack of awareness. Many people, especially in the rural area, they do not have much information about the eye care service. Where is the eye care service? Because in the community, in the health center level, and still in district referral hospital, there is no eye care service. But recently, just government started to introduce the eye care service in health center, but this is too early, and so still people do not have access for the eye care service in the health center level and district referral hospital. So only in the provincial level have the eye unit. So the problem is the lack of awareness. So where is the eye care service availability and how they can get the service? So that is also the major barrier for women. And the fear of surgery or poor outcome following surgery. So most of the people think the eye surgery must be very big and panicking, and sometimes they are not confident about the outcomes, whether after getting the service, eye care service or surgeries, whether they really get the sight restored. So that is also the barrier. And in the rural area, most of the women live in their home. They have the responsibility to take care of the children and take care of household and domestic animals. So other people, the men and most of the other family members go to work, so they do not have take care. That is also one of the barriers that they could not visit to the eye hospital or eye unit. And most of the women has the domestic duties. They need to do household work and take care of the children, and so they are just involved and busy for that. And the main thing is the eye disease are not life-threatening, so they do not much think about the going to have the eye care service, but just involved in the domestic duties. And another barrier is that they don't feel the need because the eye disease, most of the eye disease are just have the problem, but still they can see, like cataract. It grows slowly, and then they still can see, so they don't feel the need. But in case if they get injury, that is the urgency. Otherwise, they are not feeling the immediate need. And the next barrier is they don't want to travel far from home, because they have to spend a lot of time, and then also they have to pay for they think they need to pay for the service and accommodation, food, and they need to take care of to visit the eye hospital that is far from their home, and then they don't want to go far, to travel far from home. And some people, especially women, thinks they are old, and they think why they need to spend the money and the time, and why they need to disturb the take care. So they are old, so they don't want to go for the surgery. And the next barrier is the destiny, God will. And people also think that sometimes the blindness and the eye disease, this is because of the related with the God wills, or this is not something, it comes from other factor, but just from the God's will. So it will happen, it happens. So they think like that. And still in Cambodia, so majority of province have the eye unit in the provincial town, but still some of the provinces do not have the eye hospital and eye unit. And in the health center level, district level, as I mentioned, do not have the eye care service. So because of the service not availability, people are also not going to get service immediately. So that is also the barrier. Next slide, please. Yes, thanks. So we have the strategy to overcome these barriers and increase service for women. And especially we have hired, appointed field worker, and this field worker go to the community and go to house, and they test the visual acuity of the people, identify the disease, and especially cataract, pterygium. And after that, our field worker also provide the counseling to them, where the service is available and what kind of problem they have and how that can be treated. These are the counseling they provide, and that makes them confidence. And the more women are visiting to the eye unit, eye hospital. And our field workers also ask village leader, community leader to help, to encourage people come for the eye care service, surgery. So the people are convincing, and especially women are getting the service and surgery. And with the SiB initiatives, they also provide the subsidy for transportation. So women are getting the transportation to get the surgery, and after surgery we also arrange the transportation to go home back. So that also makes them to access the eye care service and the surgery, especially surgeries. And SEA also subsidize payment for the eye care service and all the surgeries, treatment. So they are getting the poor people, especially women, are getting the free of charge service. So more women are getting access for the service. And we also create awareness through IEC material, provide the leaflet to the community people, and also make radio announcement. That also help to create awareness, and the women are accessing for the eye care service. Next slide, please. So these are the processes that our field worker make the plan and go to the community, contact with the village leader, commune leader, and just make announcement to the community people, and provide the visual acuity test screen and identify the disease, provide counseling, and if they need the service, surgeries, and the field worker arrange the transportation, and we bring them to the eye hospitals and provide the service. And after eye surgery, post-op checkup, so SEA also arrange the transportation to go back to their home. This is our process of the community outreach screening, as well as providing service. This picture shows. Thanks. Next, please. Yeah, this is the initial result in the first year between July 2016 to June 2017. So especially we have put the man-man service, and SEA Cambodia achieved OPD eye examination over 59%. We have achieved provided service to the women, OPD eye examination, and eye surgeries. 65% women get eye surgeries, and medical treatment 57%. We were able to achieve, and in the community we also provided 65% screening to the women and girls. Next, please. Yes, we are. What we are looking ahead is we are also planning to create the IEC material actually for the awareness, new leaflets that mention about the cataract. We have planned to design the leaflet for cataract, elysium, glaucoma prevention and cleanness. That is in the process with a consultant from National Program for Eye Health, and that also is in the process. And SEWA also, this year we have started something new, the community outreach screening. Normally our field worker, they just go alone to screen the people and arrange the screening. But what we have planned is, we have planned to involve the eye unit, hospital eye unit staff, especially ophthalmic nurse, refractionist, to go with to join with the field workers. So field worker organize the screening that's joined by the ophthalmic nurse and refractionist and provide the services, especially medical treatment, minor medical treatment, and the refraction, as well as provide the eyeglasses on site in the community. So this is just we have started in one province, Patamang province, and if this is successful, we have planned to expand to the other provinces as well. And so also planning to set up the vision center in the district hospital, and this in this fiscal year 17-18, SEWA will provide some equipment, instrument for the refraction for the vision center in one of the provinces we are working in Kampot, and the ophthalmic nurse, he already got the training, and he's in the process of getting training for refraction. And this we are expecting to start maybe in January 2018. So these are the plan we have, and if year in flowing years. So we also have planned to set up the vision center, and next year. Thanks. And from this SIB project, since we started, we have also learned many things, especially working with the community. And what we have especially learned is the field worker mobilization has led more women accessing eye care service because of the field worker provide the screening, visual acuity tests in their community, and also they provide the counseling that also help to the women, convincing them for the eye care service, get more information, and also make involved the local community leaders, village leaders, monk religious leaders, as well as that also, yes, that is also significant to make women access eye care service. And the next is the first year project to provide the eye care service to the women is successful because of we are also closing with our government partner eye hospital eye unit to improve the quality of service, providing like training, equipment, instrument, and medical, surgical supplies, and communicate regularly with them and to improve the service. So thank you very much.
Thank you, Roshan. That was a really interesting overview of some of the challenges within your context and the gender strategies that the project is implementing, such as the providing counselling, working with the community leaders, subsidising payments, and just at the end they're talking about working with the field workers and finding out where those blockages are and how you can achieve them. So thank you so much for that. Right. Thank you. So now, listeners, it's over to you. We have quite a few questions already, so if you do want to ask any of our speakers questions, please do type them in the chat box, and then what I'll do is I'll ask them to our presenters. So I'm going to start with a question I think I'm going to address to all three of our presenters, which answered a little bit in the presentation, but a little bit more detail. So this is from Sandeep Bhutan, who's saying in most of their South Asia projects that we're engaging, We have a higher proportion of women at the primary care level, but a reversal of this pattern while accessing secondary level care facilities and thus cataract surgery. So what has been your experience with this and how have you handled these? So if we do the same order that we did the presentations in, so Samrana, if you want to start, and then Erica, and then Roshan, if you want to give us your thoughts. So, and I'll just a quick reminder to our presenters. Please do speak slowly and close to the microphone so that everyone can hear you as clearly as possible. So, Samrana, if we start with you, and then Erica, and then Roshan.
Thanks, Susan. It's a very similar kind of experience which we face over here as well. And one of the learnings, especially in context of secondary and tertiary level care, which has been for us, was that making sure that community mobilization and community sensitization aspect is embedded in the program. Because no matter what we have noticed, that even if the services are available at the district level, the surgical services or broader sophisticated refractive services, still women won't be able to even come to district hospital because they have to come along with somebody, considering the traditional or conservative aspects of our societies in South Asia. So one of the things which we have done is making sure that highlighting this aspect to raise awareness within the community, that how important it is for women to access these services, even for that, even if they have to come along with somebody to the district or tertiary level hospital in the main city or town. And relating it back to what responsibilities do they have in their particular setting and how their vision impairment is affecting that household and that village and community in general, has proven to be successful to a certain extent. The second thing which we have faced and we've tried to address is bringing the services more closer to the communities. So engaging with national programs, engaging with relevant ministries and development and finance department to develop these surgical services at the district and sub-district level to make it more easier for women and girls to access that. That has been proven to be successful to some certain extent. But I strongly feel that until the local community is up on board with this and they see a value of women getting this service and how this can enhance the quality of life, we need to make sure that that aspect is well covered.
Lovely. Thank you, Samrana. Okay, Erica. Yeah.
Okay. Yes, so the context is quite different in Myanmar in that we are seeing many more women than men accessing cataract surgeries, and to the extent that we're aware of it, other secondary eye health services as well. I think that some of the factors that may be driving that, in Myanmar, the cost of the surgery is actually free. So there are some expenses associated with travel, and the patient needs to also here get someone to come along with them to help take care of them while they're in the hospital. So there's that cost. But we're not really seeing quite the same dynamic in terms of lots of women accessing primary services and then not getting that follow-up at the secondary level.
Thank you. Okay, Roshan, finally, do you want to give us your thoughts on this question?
Yes, thanks. In Cambodia context, so still in the health center level and district referral hospital district level, even the primary eye care also not available, and especially unless we bring our service to the community by conducting outreach screening and also conducting outreach eye camp. So these are the activities helps, programs helps the women to access the service and get the surgeries. But if just if they need to come themselves, or if we just depend, if we don't support or not create awareness or not go to the community, and they will not visit, because in Cambodia context, the eye unit and hospital just located in the provincial hospital, and just recent year government initiated, Ministry of Health, the National Program for Eye Health initiated to integrate the healthcare, integrate the primary eye care into the healthcare and into the health center level, and just started. So that makes to access the women to get the primary eye care service more in the extension level in coming maybe months and days and months and years. But what we are doing is we are working closely with the community, and so in our catchment area, the women are getting more services and also the surgeries. But in overall, in the Cambodia context, still there are a lot of problems that women are not visiting in some provinces, even the men, because of the other many barriers, as I mentioned, like the cost and the distance and the service not available. These are the challenges, but we are trying to overcome. Yes, thanks.
Thank you all for that. So I've got another few questions coming in, so please do write in your question if you got something to ask for our presenters. So yes. Another question for everybody is from Manfred Mochen. So it's around using CAP surveys. So he's saying, how far do you rely on the sex disaggregated barriers to cataract services as identified in RABS, or Rapid Assessment of Avoidable Blindness? Is it worthwhile to have more in-depth surveys, for example, a CAP, Knowledge, Attitude and Practice survey, to identify specific gender-related barriers? So do any of our three presenters, do you have experience of working with CAPs to identify those gender-specific barriers? So if we do the same order, if we start with Samrana, then Erica, and then Roshan again. So Samrana.
Absolutely, Susan. I think having that qualitative aspect of knowledge, attitude, and practice within a community when it comes to gender-related barriers will give us significant knowledge that how we can design then our program and projects to make sure that the services or interventions are more gender responsive. We've done, this is not cataract specific, but we've done these CAP studies when we were starting our social enterprise projects in Pakistan. And based on, and since we were piloting that approach, so we did that in different settings, in different provincial settings. And these findings then basically guided us that what we are planning to do in a certain part of Punjab is not going to work in KP because of the local norms or traditions. So I'm absolutely for it that whenever we are doing RABs or RARES, we need to make sure that CAP studies are part of that process to give us that community perception to develop our programs.
Thank you. Thanks, Samrana. Okay, Erica.
Yes, so we also did a CAP survey at the outset of the CARET project, and definitely I agree that it needs to be done, very specific to the geographic area where you're working, and not take conclusions from one geographic area and apply them to another, even within the same country. So yes, there were a lot of findings of the CAP survey that informed the design of the project, both overall and specific to gender. One of the things that was interesting to us, and it was in one of the graphs that I showed, is that men were much more likely to report eye strain, and women were much more likely to support red eyes and dry eyes. And when I think of it from the perspective of the survey respondent, how accurate is that diagnosis really? To me, it reflects their understanding a problem of sort of general eye health strain and irritation in different ways. So we realized that in our materials and training approaches, we had to really identify all of those different types of eye health problems and explain, what the difference is, and make sure the basic health staff knew how to counsel households about them. Another thing we found in the CAP survey that was helpful is that most people, both men and women, thought that the cataract would resolve itself. So we realized, okay, we're starting at a very basic level in terms of communities' understanding of cataract, that it's even a condition that can be treated. And we also found that households really had a limited knowledge of what was available at secondary eye care centers. So as in many countries, the eye centers here grew out of the trachoma projects. So many rural community members just assumed that that's just for trachoma and didn't even understand they could seek other services there. So yeah, those are just a few examples, but definitely would advise from our experience that a CAP is really essential, especially if you have any sort of behavior change component to your project.
Excellent, thank you, Erica. Okay, Roshan, do you want to talk about your experience working with CAPs?
Yes, actually we haven't done any CAP survey, and what we are just getting the data is from the RAP survey, the national survey, and that was done in 2007. But still, here next another survey is maybe NPH planning to do next year, but still not yet confirmed. So that is a good idea, but we haven't done so. Just we have the experience of working with the community and just observational knowledge only. Thanks.
Sure, thank you. Thanks for that. Okay, we have a couple of questions now around working with women's self-help groups. So from Kwok and Pham and Sandeep. So has anyone had any experience of working with women's self-help groups, for example, livelihood groups, or working with women's unions or mass organisations? So sort of identifying women's groups specifically in order to help with the healthcare messaging or access. So any experience working with women's groups or finding women's groups? So again, if we use the same order, if we start with Samrana, then Erica and Roshan.
Yes, for some of the work which we have been doing around social entrepreneurship and child eye health programs, we are working closely with community-based organizations who are specifically working around women development programs. And so far we've had quite positive feedback and experience out of these engagements with them. The best thing out of this interaction and these partnerships is that we are managing to support them through building their capacity, and even as an organization, if we are done with the program in 3 years or 5 years time, at the end of it, these organizations, since they are grassroots organizations and these women are from the same local community, they are there to take this agenda forward. And for us, it's been quite successful, working with Girl Guides groups, working with Women Entrepreneurs Forum, working with some of the local organizations who are strengthening women development programs, especially when it comes to cottage industry, embroidery related products and stuff like that.
Thank you, thank you. That sounds great. Okay, Erica, how about you?
No, our project was really focused on strengthening the existing government health system, but I think women's self-help groups certainly is a interesting idea, particularly in areas where services might be kind of limited on the government side, and seems worth exploring.
Thank you, great. Roshan, over to you.
Yes, thank you. So we are also working with the government and local leaders, and also collaborate with some INGOs working with the community, but not a specific women's self-help group. but that is also a good idea, and that's we will explore. Thank you.
Thank you. Yes, I suppose it's about finding out what the opportunities in your particular location and what's your best sort of inroad, really. Great. Okay, so please do continue sending your questions. We've got about another just under 10 minutes. So yeah, if you want to ask a question, probably your last chance, really, because we've still got some questions around IEC, working with IEC materials and community health workers. So we've had a lot of questions around IEC materials. So one of the questions I think is specifically for Erica, but I think everyone can probably contribute. So do you measure the impact of your IEC materials, and how effective do you find them in identifying referring patients? And and someone's asking, is it possible for you to share some of your IEC materials? Because I think they're very impressed by how great they were. So I think because it's addressed to Erica, if we sort of start with Erica, so how do you measure the impact of your IEC material? And then we can hear from the others.
Yes, so we will have a inline survey for the project, which is starting soon. So that will be kind of our mechanism for measuring the impact. We have seen, generally steady increase in the number of patients that are coming to the secondary eye care centers, not only for cataract, but for other eye health services as well. So we are happy to, share those materials. We have a flip chart that the basic health staff use, and then we have 2 brochures, one specifically about cataract, and one more like an advertisement for the secondary eye care center, and 2 posters which are sort of similar to that. I think, one challenge in measuring the impact specifically of the IEC materials is that it's really the package of interventions working together that's increasing awareness and hopefully driving changes in behavior. So we will use focus group discussions to understand better why patients decided to seek care or why their awareness has increased. And I think that qualitative assessment is really important, because when you're just looking at quantitative figures, it's a bit hard to unpack where the change is coming from, whether it's the health worker and the interpersonal interaction, or whether it's materials and other things. And we're certainly happy to share things. So maybe you could put your email in the chat box, and I'd be happy to send things out.
Lovely, thank you for that, Erica. That's wonderful. Okay, great. And then, Samrana, do you have experience of measuring the impact of some of your IEC materials, or the change that is being created by them?
Yeah, we've done a couple of pre and post survey, mostly qualitative to assess the impact. But when it comes to gender-specific intervention and seeing that what has been achieved, this is something which over which we are working at right now. So in collaboration with Fred Hollows Foundation, we actually developed a training course, Gender Equity in Eye Health. We piloted it in Papua New Guinea and Pakistan earlier this year. And one of the output of these training courses were that the participants developed their gender equity plans. And they'll go back and bring one change when it comes to gender equity within their organization and program. And one of the projects is around assessing the impact of IEC material, which is very specific to bring a gender responsive change in a certain community. So I'm excited to be part of that venture, and looking forward to some of the results when they come.
Okay, thank you, Samrana. Roshan, you were mentioning that the awareness IEC materials component hasn't actually started. Really, it's the next stage for your project, for the Save Cambodia project. But do you sort of have any thoughts around this?
Yes, the IEC material, after we will get the printing, and we have planned to provide them through our field workers. They go to the community and provide the leaflet directly to the community people when they provide the screening, and that makes them create awareness. And but the challenging is the impact. So we will see if that make increase more people to visit the eye unit. Even in future, we expect them to visit themselves. Even our field worker, not every time go to screen or just encourage them, but in future that creates them that they need the eye care service, and that they can also start to visit to the hospitals. We expect, and we will try to measure the impact through the recording the statistics from our government eye hospital.
Thank you. Yes, and it'll be interesting to see how that all pans out. Now we're sort of running out of time really, so I'm just going to go with our final question before we do our wrap up, because there's been a lot of questions around working with the community health workers and field workers. So I think again this is a question for all of our three speakers, but how with your field workers, what kind of training do they have? What are their sort of, do they have a medical background for your community health workers? What kind of training do they give, and how many times would they do the follow-up to the patients? So sort of I think some questions around the background of your community health workers and their process of how many times they would follow up. So I think your sort of final comments around working with your community health workers. So again, if we do Samrana, Erica, and then Roshan, and then I think we'll probably start rounding up.
For our community-based refractive services program, we work with a mixed group. So we have, let's say, for example, in Pakistan, lady health workers. We engage with them, train them in primary eye care and vision screening. But at the same time, we've been training teachers, we've been training trained midwives, which is as part of our social entrepreneurship program. And within that program, there is the social business component is also attached to that. So it's not only community-based workers, it's a mixed, wider group of women and men working in their local communities to provide health and education-related services. When it comes to follow-up, it's a cycle. Since most of the stuff is around primary eye care and vision screening, it varies from region to region. Region to region means province or local communities to communities, because it's directly associated with population density as well. So for 6 months to 1 year, follow up based on the need of that local community or that specific person which has been assessed by the community-based worker or lady health worker.
Okay, thank you. Thanks, Samrana. Erica, how about you?
Yeah, so our kind of equivalent cadre to the lady health worker is the basic health staff. And as I mentioned, the majority of them are midwives, though some of them have some basic nursing training or they have trained as a medical technician. So unfortunately, they follow up after cataract surgery maybe once with the patient, but they're really linking their eye care work in the communities with their ongoing visits. So if the basic health worker goes back to that village for another purpose, she'll follow up, but the onus is really on the patient to return to the secondary eye care center for their follow-up visit. And this is one of the reasons why we found it quite effective to increase our engagement of the volunteers, because even though they don't really have formal medical training other than what they've received from our project and similar projects in different subsectors of health, they are there in the community and are able to remind the patient that they need to follow up and even find some resources for them to do so if that's a challenge in terms of finding transport or someone to go with them.
Okay, thank you. Okay, and finally, Roshan.
Yes, yes. SEA field worker, they are non-technical person, but we provide training, especially the primary eye care training, the training of trainers. So that is ophthalmic nurse or doctor have the training of trainers. So TOT train the field workers. Actually, they do not have the medical background, but just to provide the primary eye care training 1 week, the theory plus practical, and also in the field 1 week. So the TOT just provide how to identify the disease, especially test the visual acuity and identify the main disease, cataract, pterygium, and if there is a other disease, they also can some disease identify, but they don't provide any treatment, just identify the disease and make the referral. And these all patients when bring to the eye hospital, so there is an ophthalmic nurse and refraction nurse doctor will examine, and they decide that the after final examination, if the patient really need the what kind of service they need and what diagnosis they have. So this is in the field. What does the field worker do? This is just to identify, but that is not the final stage. So that depends on the technical medical person in the eye hospital after checking. And especially our field worker make the routine schedule to visit the community and the village. And so in, for example, in one province we have some province 3 field workers, some province 2 field workers. So we have divided the district, and they make the schedule, and if the rotation wise they go to one after the another community, and that if they screen in one place maybe every 3 or 4 months, they repeat the same village, they again go to screen and test the visual acuity and make the referral. So this is the process we are working. Thank you very much.
Great. Thank you so much. Now, I think we're out of time really for questions now, but thank you so much for all of your participation. Some really interesting questions coming up, and thank you also to our panelists for responding to those questions. If you did have a question that you wanted to ask a presenter and you didn't have a chance to, you can email me your question after this event and I will forward your email to the presenter. And then you can directly hear from them. So thanks once again, everyone. So I would now like to introduce Sally Crook, the Seeing is Believing Programme Manager for IPB, for some concluding remarks. So Sally, over to you, if you want to unmute your microphone.
Okay, hello everybody, and many thanks to the 3 presenters. I thought that the great sort of range of issues that were covered there, and what people are grappling with. As possibly many of you know, gender is one of my sort of key things, which I think is very important in healthcare in general and in eye care in particular. One thing I'm going to talk about, which hasn't come up on this call so far, is that we are hoping that there's going to be a new gender manual for eye health programs coming out very soon. I saw earlier Camilla was on one of the attendees, but I see she's dropped off now. But she has sort of been leading on this, and we hope the document is now ready. And it's been supported by many of the INGOs, so it's a great manual which I think everybody will find very, very useful, having listened to both the presentations and what people are grappling with, and then also some of the questions and what the issues are. Anyway, so from that manual, when you get it, it's on pages sort of like 13, 14. Some of you might have access to it because your organisation has been involved in developing the manual. There's a great little box, and it's sort of saying what we need to do to really address and deliver gender responsive projects. And the first thing they say is we all need to reach higher, which I think sort of links in with what Simrana was saying at the beginning, is that we all need to sort of have this awareness about the issue and to make a contribution in trying to reduce inequity or improve equity across all our projects. And you know, with gender, it is a really cross-cutting issue, because it's often gender and old age and you know, rural inaccessible areas and everything. There's lots of sort of cross-cutting equitable issues there. So I think, yes, we all need to aim higher, reach higher. The next thing they talk about is that the priorities will vary from one location to another, and I think that was brought out very neatly between Erica's and Roshan's presentations. You know, what are the issues for your community that you're working with, and how are you going to address it? But even among women, they're not a homogenous group. I mean, I think a lot of us know that, you know, huge differences between rural and urban communities and their access to services and things, and their knowledge and awareness. And also, you know, different men's knowledge is very different in how they can support women accessing services. I think it's come out very strongly how services need to be community-based, whether you're talking about working with your village health workers, working with teachers, leaders, whether they're community leaders or religious leaders. They need a lot of links to make them very accessible to people. And also an issue that's come up is about tapping into the expertise of others. And I think within the health system there are projects and programs which have addressed sort of gender inequity and have, you know, great ideas as to how you can address this. But the other big thing that's come up is data, and more data, and disaggregate it and analyze it. Because I thought, you know, you can just really see what the need is. Like when Roshan said that, you know, from their RA, blindness was 4.4% among the women and 2.7% among the men. I mean, this is a huge difference, and clearly you need to have a very active response to differences of that sort of magnitude. And then we've heard quite a bit about the CSR rates, but I think CSC for gender can also be very helpful in informing you whether you are reaching women in the rates that you would expect, considering your local population. Because again, in some areas we know that in a rural community there might be a lot of elderly women, many more than elderly men, so it's going to affect your patient workload and what you should expect to see. And I also liked the discussion at the end about working with women's groups or something. You know, how do we access women? How do we encourage them to have confidence in the service and come forward for the service? And as I was mentioning at the beginning, this intersection between gender and the elderly means that I have seen in Asia some great work done by working with elder groups or old age groups. So although they're not specifically working with women, actually when people go to these elder groups, you will find that possibly 70% of the people in the group are women. That although it's not set up as being predominantly women, because as women you know, live longer than men, and also they do attend these sort of social events more, that you will reach out to women who need eye care services by working through elder groups. And I think we have had some great examples in the Community Eye Health Journal of trying to access women and older women in particular, and that's been a great sort of strategy there. So when the gender manual does get finally signed off and put up on the, I think it will go on the IPB website, I would recommend it. As you can see, Susan's got the sort of the front page up at the moment, and that is going to be really very positive in helping us to think through what's going on and how we can really link in with thinking about being gender responsive. Okay, that's all from me. Thank you very much. But I've really enjoyed the webinar today. Thanks.
Thank you, Sally, and thanks for drawing our attention to the Gender Manual for Eye Health Programmes. We'll sure send a link round when it's sort of made available. But thank you for that summary of that presentation, the presentations today. So I'm going to end now. So I'd like to end by thanking all of our presenters, Sabrana, Roshan, Erica and Sally, for their comprehensive presentations and the responses to all of our questions. I'd like to thank Saloni and Emma for all the technical support, and a huge thank you to all of you who have participated. I really appreciate you taking the time to be part of our SiB Learning community. And if you would like to share your own gender strategies with our SiB community, gender is one of the themes for the next Seeing is Believing newsletter. So you're welcome to submit articles to me by the end of November. And I have just one final favour. I'm now going to email you all the Seeing is Believing webinar survey, which should just take 5 minutes to complete. And please do, as your support for these webinars makes them possible and your feedback helps us to improve them. So thanks again to everyone, and I look forward to seeing you all at future Seeing is Believing webinars. Thanks all.
Thank you very much.
Thank you.
Thank you.